have been researcher, trainer, consultant, so done all sorts of things, and also looked how the approach to the training has changed during different decades. So my presentation mostly tell you now what are the technical report which was published 2012, what does it underline, and how we have done this training guidance in Finland via the Finnish ergonomic patient handling passport. And this, in years 2003 and 2007, ISO has produced specific ergonomic standards 12,228 series addressing manual handling in general. However, they don't cover the manual handling side of living persons. So in Europe is active for 10 years European panel on patient handling ergonomics. And we provided expert support for this technical report making. EPHE, this panel was formed 2004 as a collaboration of experts from International Ergonomic Association, 2 technical committees. The Technical Committee on Healthcare Ergonomics and Musculoskeletal Disorders. And it was Professor Occipinti from Italy who then suggested that we would start to make the guidelines, this patient handling guideline. And also Sue Hignett from UK is leading, actually at the moment leading that group, but at the beginning they both were leading. And the objectives of this group is to share information about research on patient handling, create research ideas for European collaboration, and plan for future conferences. For example, now the next conference where we will be present is the Krakow conference. 2012, EPHE extended worldwide, and it's now international panel of patient handling ergonomics and has 100 members at the moment. So what is this technical report? I would like now first ask how many of you have been in touch with this technical report already or even read it? Could you raise hand, please? Few hands are rising, fine, but not very many. So I tell about it, overview, and basically more profoundly the staff education training part, which I was the responsible group leader. So technical report gives an overview of evidence-based methods to assess problems and risk associated with manual patient handling. And also details how to identify and apply strategies and solutions to reduce this risk. So the content of ISO technical report is risk estimation and evaluation, organizational aspects, aids and equipment, building and environment, staff education and training, and also evaluation and intervention effectiveness. Technical report is a copyright paper, and it can be bought in the internet in address what is in this slide. But the writing group also wanted to make it more, in a way, public, that it exists, writing a scientific article in the International Journal of Industrial Ergonomics. And Arjo has got the permit to publish easy to read edited summary about it, and it's available in the internet page. Technical report has two major objectives: to improve caregivers' working condition by decreasing the risk of biomechanical overload, limiting work-related illness and injury, and consequent absenteeism or cost, but also to ensure patients' quality of care, safety, dignity, and privacy while continuing to meet their needs, including personal care and hygiene. And this is the surely familiar risk assessment process. But this technical report emphasizes that at risk assessment should consider the presence of several risk factors and how they are related. So type of the patient, induced the care load, available caregiver staff, available and adequate equipment, building environment and spaces, and also then the training and skill of nursing staff. In the report, there are presented a number of evidence-based methods for risk assessment in safe patient handling, but 4 practical methods have chosen, and they are applied a common scenario. They are presented Dortmund approach, which is a German method based on the EMG measurements, Italian MAPO index, Finnish patient transfer assessment instrument, which is the picture here, and it exists also nowadays in English, and in this address, which is there, you can see, and then the Dutch geothermometer, which is being freely available in internet. And building and environment side, these bases are more, there are a lot of information about these spaces. My pictures here show the Finnish toilet design, and we have an architect Pirjo Sipiläinen who has done her doctoral thesis about the elderly people how they manage at home and how should their hygiene facilities be designed. This is one of her recommendations which is there. Like you see in those graphics, there are a lot of different supports beside the toilet seat, and then is the, can I use this? Yes, this design, what is here, is more or less like that, and the support is around the washing base. That is actually for elderly people very handy solution. It seems to be that the market has available several of those models now in different countries, not only Finland. But if you need more information about this, is nicely collected in this technical report, a lot information. And then I go to this staff education and training, which was in my responsibility, but I must also thank for the Irish member, Sarah Dockrell was in this group and helped also to formulate ideas to this subject. But the first thing I take up, what also Frank emphasized a lot, we must always question, is the education effective? The results are showing and it hasn't been always effective. There is the Suhignet's result showing that if the intervention predominantly based on technique training had no impact on back pain and injury rates. It might of course affect somewhere, but mostly we want to have especially the work lighter and less back pain and injury rates. Then USA, they say it slightly differently, but same thing. Training caregivers in how to use proper body mechanics to lift residents is not an effective prevention measure because lifting the weight of adult patients is intrinsically unsafe. But we also must remember that we actually maybe don't really teach lifting. We actually, I feel always in Finland, when it's question of safe patient handling, I'm teaching healthcare workers how to do the work so that we activate the patient as much as possible and not really lift. So we are teaching how the human body can be most optimally being moved. It's much more, rehabilitative than, it's not really lifting training. And then multi-factor intervention based on a risk assessment program are most likely to be successful in reducing risk factors related to patient handling. There is several studies from that too, and my own experience it's not only that you focus your training correctly after when you have done the risk assessment, but also you take consideration all possible risk what is there. You know, you always can't do that though, but the main risks. And then one thing, whom you then train when they have been in the process of assessment, they understand the risks better. There exist risks which somebody else can take away, but in patient handling, the risks can't fully be taken by somebody else. You must also change your own behavior, and I think that understanding that in this process is very important. So, aim of the training is that you promote the right behavioral and attitudinal changes, safe working practices, less physical exertion, and improvement in quality of care. To be able to create behavioral and attitudinal changes in several other things must be taken into consideration. There are these more or less same things, but there are also learning innovation in the organization, and the management is in red because it is the most important. Without management making the plans and policy and support for the work, nothing is succeeded. That is my experience. That I partly spoke already, so multi-factor interventions. And in USA especially, there have come results which shows that if you incorporate these lifting programs, mechanical lifting devices, and then you can protect workers from injury. That is, I think, obvious. That must be done, and it's certainly one of the easiest way. But how is the care, quality of care, that one always asks. And Holland is maybe the far with the research and experience at implementation of full policy is cost effective, but it takes time from 2 to 4 years. I have also experience from Finland that often managers expect that you have results in 1-2 years, and it usually does take longer. I will tell you later one intervention in Finland which just shows quite nice results. It's 4 years now when it started. And the same what Frank said, just a training should be part of the risk management system of the organization. This is a direct text from the technical report. So, safe handling policy where the organization commits itself to actions to reduce risk for the staff. Responsibilities of line managers and staff. This is a big issue anyhow in Finland. I was last week in Rovaniemi, northern Finland. We had a meeting of we have a cooperation group in a way. They are mainly patient handling instructors and physiotherapists and teachers, and discussing about how to implement these matters, and very much came up how we get the managers to understand this matter. There are managers who understand, others who tell you that we don't do that work, but they don't understand that they should lead that work safer. It's sometimes, and I think one thing is when I'm analyzing why is the managers understand it so badly is because what education they have got. When they have gone to polytechnics and things studied, they have not studied ergonomics at all. Further, they study management, but not what they're managing. So if they don't themselves search the training of ergonomics, their understanding about the matter is poor. Only thing what they really understand is then money. So you must speak with the money language. This is a very important matter in an organization. You establish the role of key workers, or whatever you call it here in Ireland. I mean the person who is supporting co-workers to implement the good practice. Anyhow, it seems to work in Finland well, and in Holland I know, and maybe here too. And the last thing is a training program should also ensure the training of link persons. For example, clinical educators who provide the link between the clinical setting and any university or college. I have, after my doctoral thesis, where I studied different lifting techniques and how physically strenuous they were, I started to project to improve the training in the vocational education of healthcare workers. And one part of it was that I collected a group of teachers with whom we planned what should be in those colleges taught. And we got the teacher's manual, nice impact booklet, where we tell them, and then we looked the methods, what to teach, and then they taught to their own students. I hired an outside evaluator who then looked the results, what the student knew after that new training system. And it came clearly out at those students which went after the ergonomic training to the field practice and were not able to deepen their knowledge and skills there. In other words, they were old-fashioned methods usage. They forgot the taught methods, and when they came back to school and to this evaluation test, they performed very badly. The best result was from the school, where in the field also the new methods were already used. So clear conclusion from this intervention was that the change in the society must happen hand to hand in the colleges and also at the workplaces. When you try to teach on the other places, in Finland it is now so that the change happens in both places, at the schools, vocational school, colleges, polytechnics, and the workplaces. And in the places where it's already established, it seemed to bring nice results. Then a few words about how to organize the training program. So this is now said that it should incorporate the management and include all levels of staff. Provide appropriate equipment. We often do in Finland so that if the unit and organization have very few assistive devices, then in the training they try different one, and after then they make the plan or buying the products what they find useful. Then in technical report says also they should define the competencies of trainer, key and health worker. And technical report defines the competencies of health worker. And that I have now present so at how we have implied those competencies of health worker in Finnish ergonomic patient handling passport. UK has first been publishing the competencies, these competencies already 2003. 2008 was in Wales, the old Wales manual handling training passport. And if I'm right, the Ireland got 2011 this guidance ready, and we in Finland 2009 ergonomic patient handling passport, which I now tell you a little bit more detailed. What does it keep inside? Here is the wholeness. There is first e-learning for 2 months, where you have to do 4 tasks. In a way, doing them is the exam 1. Then you have 16 hours practical training. And 1 month you are implementing then in your workplace, and you come the 1 day exam day after that. And here you see the picture of passport, and it is valid for 5 years. After then you have to have a 1 day refreshment course. And we have defined the aim of the passport this is to it's define the competencies, skills and knowledge levels needed to be able to perform the patient transfers safely and of course to learn them too. Ensure compliance with legislative requirements to improve patient safety and quality of care, and through the exam nurses can prove their competence. Then we also have introduced the trainer education for those who have passed the passport training well. So they can come and have 3 days trainer education. So a little bit more detailed of this e-learning. You first read those things what are there in the black. There is risk assessment, there is physical load of different lifting techniques, ergonomics of work environment, there is about working ability, quite a lot reading. This is quite heavy task. Then there is the pictures you must analyze and write an essay about them, answer to the questions which exist. And with those first tasks, we think that it is covering at least partly these green text, which are the technical report competencies for healthcare nurses. I don't read them usually, can read them yourself there. But here you see that also the highest of my doctoral thesis, unfortunately it's only in Finnish. Then the new patient handling guidebook, it first was written, I was writing it with Professor Wikström 14 years ago, and now last year it was a new edition and up-to-date text in it. And here is then, Frank was talking about policy, simple, and we have found in Finland that we must also make those managers a simple guidebook, how to do the risk assessment and this policy making. This is that book about that. It's just a very simple what to do, what you should take into the consideration. That book, by the way, that is translated in English too and is available in Finnish Occupational Health Institute internet pages in section English. You can find it there. So it's a management model for physical risk in the care work. But I'm still mentioning about this, the physical load of different tasks. This is completely horrible slide from an educational point of view, completely too much information. Those students in passport course, they're reading about these results of the different biomechanical measurements, and for example this German Dortmund study group's results are shown to them and explained and discussed. I show them here too to just show that when these results are all collected, let's say Germans have put them, all the results which they have done in the same slide, and they have put behind the risk assessment, the red area, the yellow area, and green, which is okay. So you can see at 15 tasks which they have studied, very many of them goes even to the red one and yellow are almost all. The highest is the 3, moving the patient towards the bed's head, caregiver at the long side. And then they have studied it the so-called conventional method, which means in a way old-fashioned method. Then optimized, they have been teaching the better method. Then the curve is a little bit down, and then also optimized method and aid. So if we look at a little bit more carefully, let's look. It's almost 7 kilonewton, the compressive force on the L5, L6. Optimized method 5/5. And when you use also then aid, what means in this special case mostly some sliding material. If you assist the patient from the bed's head in a way what the night nurses very often do, that is reducing the compressive forces a lot. Another very high is there, 13, is placing the patient from bed edge in the chair. As normal assistant, there is very high too. That's the one which American Maras got the highest compressive forces. But when you look at this, and then you certainly realize at many of the works what the healthcare workers do, they are risky actions if you don't improve them. Okay, then we go back to the content of e-learning. The second task is they are reading about the body control and keeping a diary one's own body control exercises. Nowadays even for 4 weeks. We had it first at 2 weeks, but then we realized that they need longer. Because very many healthcare workers nowadays, they don't really use their body very well. These body control exercises are very close Tai Chi type of exercise, very small exercises, but you must especially experience how your body gives you feedback. How does it feel? Where is your weight? They are very, very simple. For example, you just take weight in forwards and you must feel how does it feel in your body when your weight is here on that length and that length. And then you do rotation, you start to sense where is your body's middle line. Some people don't understand them at all, but some realizes that they have the so-called proprioceptive sense in their body and they can improve it. That can be improved if you concentrate and do it. And so this helps when they come to the practical exercises, they should be able to use their body control, the body a better way. The third task is get acquainted with existing assistive devices and hoist, first of all, in your own workplace, and if you don't have them very much, then they must search them in internet what does exist or go to the shop to look. But for this task, they read basic biomechanical principles, and then the task is how to apply the biomechanical principles when you use different helping devices. Because when you look normal practical work, sometimes they use completely phonily, for example, sliding material, they have not the idea there behind how to use it. You must understand how to improve the sliding and where to put it to the underneath the patient, and in very many other helping devices to get the best and creative usage of them. You must understand biomechanics a little bit. This is the most demanding task for practical nurses usually. At the beginning we didn't have the very good simple biomechanical text in Finnish. Now we have been writing it in this new book, the basic words and text, so simple form that we haven't got so much complaints anymore about that section. And the final task in e-learning is to reading Finnish laws and then discussing with fellow students about 2 scenarios. The scenarios are typical happenings in the unit, something goes wrong, and then they must read and find from the laws what the law says about. People know the laws and regulations usually badly, even the management size. It's surprising, and these are taught in vocational schools, but our experience is that if you are a young student and no touch to the work life, you don't understand interesting laws at all. When they're in work life, they start to understand it, and actually some students even like at this task is really good. In Finland there is about 10 different in a way laws which are connected in safe patient handling situation. So if you would just read the laws on its own, it would be boring, but discussing with others and this task comes quite fun. So all to this they have 2 months time to do, and then start the practical training. And rest of these core competencies of healthcare workers are applied in that session. They are here in green. I let you to read them. You can better read them. I pronounce them, so I have a drink of water. The number 3, ability to use verbal and tactile interaction to optimize the patient's own resources and encourage their independence. That I have noticed is quite, in a way, new. Verbal, of course, they use, but this tactile interaction is very important for the patients who are not able to move a lot. If they are mainly bed rested and their own ability, they sit in the daytime, they lose in a way, how to say now it in English, their own feeling of body and how to, in a way, move very much. So very often it is they have ability to still do something, but if nurse just goes and verbally instructs the patient, she is not able to hardly anything, but is it also touched or helped to move first and then ask the patient to move, it works. It's a very important part of it. And the 6th point, this is anyhow in Finland, ability to document the patient condition, chosen method to assist the patient and needed aids to care plan. This part, how it is usually documented in the patient's papers, is just said with one word often. One nurse is able to assist or need lift. We try to teach them that it must be more precise so that somebody else reading it understands really what to do, and also that there are more ways to do that than only that one. This thinking of one nurse, it's like they thinking it's just one way to one nurse can help another person to move. That is not true. It's 1,000 ways to do it, so you must more precisely to document it to the papers. This is the practical training which covers those competencies, anyhow we think so. Very simple, assist them to those first things: patient's conditions, functional ability, and then the principle of normal movement in order to move optimally when involved, and promote favorable movements patterns and optimal independence for the patients. This is the part which sounds nice, and when you are in these meetings and conferences, everybody says something similar, it sounds similar, but when you start to look at it in practice, what it involves, it might be quite different. We had once, some years ago, quite many years ago, in Paris conference, there were 13 different methods presented in practice, and one could see how differently one does still certain things. And I tell you now what I found in Finland, which is in a way useful, is that when one wrote the first guidebook 14 years ago, I tried to get touch as many guidebooks in the world, what I maybe had about 15, and I looked the methods which in those books had, and find out that all the methods that time were so-called two-dimensional assistances. And what we know about normal motor control and management is that three-dimensional movements are easier. And if we try to imply this now to patient handling, it means that we shouldn't assist patients to move in two-dimensional way. If I show you, because if you don't understand what I mean with two-dimensional and three-dimensional movement, I looked at the new booklet which is published today. There was three-dimensional movement alone, but not necessarily mentioned that way. If I get up like this is two-dimensional movement, and if I assist the patient three-dimensionally, it means that I start to rotate and do it like that. Then in most of the movement points on my body, there is rotation, and it is easier. Elite sport people use almost always rotation, and it is easier. And then so many years ago, they hardly existed. It wasn't any guidebook. It was actually then I realized that all the guidebooks showed two-dimensional ways. And then one human body needs much more power, much more control to balance when it is two-dimensional. When you do the movement three-dimensional, and on top of it, give the support outside of yourself. It's easier for you, it's easier for patient. In my doctoral thesis, the physical load with those nurses who then were trained, it went down in the back muscles to the half, neck muscles 1/3. So one can reduce the physical load when you teach the right way to assist. And essential is that outside support, which you will also, it doesn't need to have anything special, but as long as the patient has power and could use the hands, it's always worth to think, where do I let her to take grip and touch, not to yourself. Yeah, activation I spoke already. Then also, of course, those applying different situations, that is obvious. Then you must learn to use those assistive products and lifts. And then you practice, they are taught about documentation, we are talking about it, but the final thing is at an exam, after they have done perform the task what are asked, they must tell still, what would you document from this performance now to the papers. Okay. Yeah, here you see in this picture now there is just given chair in front of the patient. The nurse is stimulating the tight muscles, and the patients can in a way use it better when you get the connection to it. Okay, so application time for 1 month. They return to their workplace and deepen their skills. And if they find that something doesn't work as likely as it should, when they come then that exam day, half a day will be used for rehearsal. If they have come across with the problems, or then they will just rehearse what they want, and then afternoon start the exam, where they do 2 transfers, one manually and one by a hoist. They are filmed, those transfers, and 2 qualified passport trainers evaluate them according to agreed criteria. Here we see in Finland we are slightly, Finnish population is 5.2. I know that Ireland has a little bit less. We have now 200 trained instructors. 40% are teachers from different levels of professional training, and 40% occupational physiotherapists, which very much act in a way instructors at the workplaces. Rest are nurses, physios, municipal or private sector. And passport became ready 2009 after 2 years piloting phase with social ministry financing, and now we have 3,400 passports, and it's quite well throughout the country. Here still a few words about how to organize the training program from technical report. And the first thing, patient handling requires knowledge, skills and attitude, right attitude. And that's why the training program must include theoretical and hands-on practice. I was training for a long time, 2 days, and 1/4 of day went to the theoretical practice before this passport training. And I do find it much better like this, that they understand the basic theoretical matters first, then they come to the practice training, and then it's still deepened and applied in reality. This training really feels that it works. The Frank mentioned also that already, the content of training ought to be tailored to the needs of staff and patients and should be based on risk assessment. And then is a time allocation to the skill training. I think this is really one thing which people think wrongly, especially management. You often are asked to train few hours, makes one almost angry. Because, of course, depends on the starting levels. Few hours is all right if the starting level, that there is certain knowledge and skill existing. But often there are places where they are just on the ground level. So you don't reach very much. But the management thinks that now the law is fulfilled when they have given some training. And they do have done the risk assessment, but it's done by somebody else, not with the people who really understand that this risk is touching me. If it does, the certain people a little bit outside the unit, head nurse might be along it, unit manager, but nevertheless, the knowledge of the risks doesn't reach the floor level workers. And I think then the risk management, of course, it can be helped, they are done improvement, but it doesn't help the worker to understand what she must do to improve the situation and take the risk from herself and her own behavior away. So there is still, all new staff require comprehensive training. The after training is ongoing process. And in technical report, it came after discussion. Refresher training required at least every 3 years. I know there is countries where it is every year, every second year. It depends on which agreement has been, but in technical report it now stated like this. I think every second year would be often needed. But if you have those instructors in the unit, then it's no problem. So those key workers, they have better trained, they can assist and help others to improve. Okay. And then comes this effectiveness of ergonomic passport training in Finland. We haven't had yet possibility to do proper research, evaluation research. We are planning of it, but I tell you here from two smaller things. There is a qualitative study of the effectiveness by Anne Henriksson, and she found when she interviewed those nurses that transfer skill and ability to assess risk have improved, work and patient safety have improved, usage of assistive devices and hoist have increased. The units implemented safer working techniques, so the person has been able to spread the knowledge to peer workers, and they use body in more ergonomic way, encourage patients to move more, adapted the assisting to patients' functional capacity. But then this is the Rovaniemi long-term care unit where at the end of last year we were reading from newspaper that they are awarded a well-being prize. And the story is that they started ergonomic patient handling passport training in 2009. I remember that was the pilot stage at the end when I was training in northern Finland, the first nurses, and from that unit, which is now in question, there were 2 nurses. Now, 2014, unit has 10 passport-trained nurses and 1 instructor. And they have assistive devices, earlier 3 hoist, and then after training they have been buying sliding gloves, walking belts, different sliding materials, standing aids, and altogether invested in that 4 years 6,000 euros. And the 4-year statistic in sick leaves is that it has 600 days reduction in sick leaves. And that's why the city of Rovaniemi awarded them well-being prize. I did rough calculation at reduction on these sick leave days. What does it cost 600 days? We count in Finland the nurse's salary and replacement salary, and it's about 300 euro. So 600 times 300 euro is 180,000 euros. And investment for training and acquisition amount to approximately only 20,000 euro. So this has been very well covering the return of the investment in this case. But now, like I mentioned earlier, we were Rovaniemi, we listened to the to the head of the unit nurse, and she told also, which we didn't be able to count in the euros. She said that quality of care has improved because nurses work in more patient-activating way. Patients react less aggressively towards nurses because they are more skillful. That came also in my doctoral thesis. Well, I asked the patients, and it came clearly they rated the much better the nurses who has been trained. The work is better planned than before. We do not need so many replacement nurses. Recruiting and teaching time is saved. The working atmosphere is better when people are in less pain when working. So you achieve many other positive results too. And I'm really happy about this. It seems to work, even if somebody might think it is quite a lot investment to put the nurses so long training. I do know some other places they do train even longer, but this seems to be reaching a certain basic level for safe handling. Then another thing which I want to mention, but I didn't get the slides yet. There were Finnish main municipal insurance company person telling statistic, what does it cost for the organization when somebody has to leave earlier pension, sick leave pension, then you are moving in completely different euro level to those euros which I told you one can put one more at the end. So if you can prolong somebody's staying in work 1, 2 years or even until the normal pension age, the organization really saves quickly millions. So this is the important work we do, but it is, I would say, been doing in different projects and things, and I'm still carrying it after leaving the Finnish Institute or retiring from there is really that's why, because this is a challenging work, very interesting work, and when you finally get really results which you want, you are also very satisfied. And another thing is still, also we made a small study to the schools and asked, are the teaching in school improved? And it is really now changed. Some schools have taken patient handling passport training into their curriculums. In some, only some compulsory, the others it is in a way you can choose it as a privilege. But usually students like it. It's just the tight curriculum schedules which protects it, and it is not so easily taking. It does take longer than one wishes, but it goes forward. So this effectiveness training is very important, and here are the things which I think personally is very important, and there is also measuring performance measurements. There is the Swedish Dino, and then is the Finnish SOPMAS, which I invented with Virpi Hantikainen in my doctoral thesis stage, and which is also translated nowadays in English. And just to give you a little glimpse into it, it's based and built on so-called learning, solo learning taxonomy. We call this now SOPMAS, and we look at the interaction between patient and the worker. How well the worker is able to activate the person and does it in a very correct way. We look at the patient's movements, nursing working posture and movements, because very many other instruments, they mainly look this nurse's working posture. Of course it's for physical exposure, but this is really competence in a way, competence measure too. And then how they use environment and helping devices. You can have it from me, the address, if you are interested. Actually, you can find it also in my internet page. And here still as a final, Mike Frey did his doctoral thesis in UK a couple of years ago, studying these intervention measurements, and got incredible amount of different possibilities. It's of course so many I can't use, but these are things which I have noticed in Finland, and these outcome measures, how to measure, people really, of course they are practical people, they are not researchers, but so much research mind and evaluation mind everybody should have, and they pick up some measurements if they do, how does it work in practice. Okay, that's all what I was thinking.